everybody, and welcome to this session at the Health Services Research UK conference entitled Multiple Long-Term Conditions Research, Where Next? My name is Simon Denegry. I'm the Executive Director at the Academy of Medical Sciences and formerly of NIHR and Involve. I was thinking this morning that in the many occasions that I've been at this conference before, I was usually in one of the headline slots very early in the morning, and people were usually quite jaded after the conference dinner. This time, I think some people might be a little bit jaded for other reasons still, but for good reasons nonetheless. But welcome, it's lovely to see you, and I'm really looking forward to this session. Sophie, can we have the first title slide, please? So this afternoon, this session has two main aims, really. One is to facilitate a discussion on how we can build on developments in multiple long-term conditions research and the need to put people at the heart of that agenda, people and their carers at the heart of that research agenda, and also focus on how we can ensure research is pulled through into practice for patient benefit. And I'm particularly pleased to be chairing this session, not just because of my own passion for this area, but also, as some of you may know, in 2018, the Academy of Medical Sciences published its first international policy report, which summarised the available evidence on multiple long-term conditions and highlighted key evidence gaps. Since when, we've seen the creation of a very active cross-funder forum on the area, which I think has done a lot to take forward and remove some of the barriers to further progress. So I'm looking forward to hearing about that, but also thinking about what we should be doing next. So the way we're going to run the session is you're going to hear from 5 excellent speakers in consecutive order. We're not going to break in between those, but at the end of that, we're then going to take a Q&A and discussion. And you can do that either by putting your hand up or contributing through the chat function. I know you're all well versed with Zoom after many months of doing this, but 2 quick things. If you could keep your microphone on mute as much as possible, that would be great to prevent any background noise. Just also to say closed captioning is available if you need it. So without any further ado, let's go on to our first speaker, a former colleague of mine, Leanne Dew from the National Institute for Health Research, who's going to talk about multiple long-term conditions as a strategic priority for NIHR. Over to you, Leanne.
Brilliant. Thanks, Simon. And great to see so many people on the call today. Thank you for coming along, even though I know it's over lunchtime. Hopefully you've got a sandwich or something to eat while you listen and contribute. So we're looking forward to having a really good discussion about what we as funders can do to support and encourage more creative research in this space. And we want to build on the great work that you as the research community have done already in this area and the new initiatives that various funders have put in place over the last couple of years. So as Simon said, my name's Leanne Dew, and along with Natalie Owen, who's also at the workshop today, we lead the NIHR Multiple Long-Term Conditions Research Programme. We're also core members of the cross-funder group on multiple long-term conditions research, working alongside colleagues from the Medical Research Council, AMS and Wellcome. So whilst the NIHR has funded research into multiple long-term conditions and complex care needs since its inception, it now recognises these as strategic priority areas. Our commitment to those are outlined in both the NIHR Best Research for Best Health, the Next Chapter document published recently, and in our NIHR Strategic Framework for Multiple Long-Term Conditions, but I'll come back to that shortly. Concentrated work on multiple long-term conditions really kicked off in 2018, as Simon said, with the fantastic Academy of Medical Sciences report, Multimorbidity, a Priority for Global Health Research, which involved contributions from across the research community and the different funding bodies too. Following that, the AMS, NIHR, MRC and Wellcome then came together to coordinate a multiple long-term conditions research funders group, working alongside numerous other research charities, including the Richmond Group, and we'll hear from Eve Riley later on. This group of funders, which includes, as I said, many different charities, published a cross-funder multiple long-term conditions research framework, which aims to help coordinate the efforts and initiatives of the various funders. And it also embraces the multidisciplinary nature of the problem and recognises that working in partnership will really help, hopefully, to shift some of these common barriers. And then we as NIHR have outlined how our priorities and our work align with this wider cross-funder effort in our NIHR multiple long-term conditions strategic framework. This sets out our evidence aims around multiple long-term conditions research, but also the cultural and process-based changes that we need to make in order to fully facilitate and support the multiple long-term conditions research needed to improve the outcomes and provide more efficient and effective care for people with multiple long-term conditions. And putting people and what matters to people and their carers at the heart of our work has been really vital and is a theme that we'll pick up across this workshop. So we've outlined 4 key evidence gaps or evidence aims. These are very broad and we will build on these in the future. The first one is around identifying common clusters of disease and their trajectories. The second is around identifying the problems and outcomes that matter most to patients and carers and how they would like to see the health and care services configured to best meet their needs. The third aim is around funding research that enables the health and social care system to take a patient-centred whole person approach to treatment and care for people with multiple long-term conditions. And the fourth aim is around supporting the design and delivery of interventions to prevent patients or people progressing from 1 long-term condition to 2 to 3 to 4 to 10. And whilst we've put a substantial amount of funding in clustering work to date, this is by no means our only focus, and we're really excited to be scoping funding opportunities which speak to these other aims in the NIHR framework. And we really encourage applications on these themes or any research into multiple long-term conditions to come through our researcher-led commissioning calls across our NIHR programmes too. And as you hopefully will have noticed, a number of these evidence gaps will require health services research to really help address them and get under the skin of them. Next slide, please. So I've already mentioned that we're aware that we need to change our cultures and our practices to be more supportive of multiple long-term conditions research, and we've already started a number of initiatives in this space. I won't go into the detail on this slide, but just to highlight that we are looking at different ways of doing things and that this is a living document. For instance, we already know that we need to add clinical education onto this slide if we're really going to see successful pull through into practice, and I'm sure there'll be other things that come up along the way that we need to include or highlight. I mentioned that we're scoping new funding opportunities, and some of these will be of particular interest to you guys in the health services research community. And I'd love to see people here keeping an eye out for these and applying when they come along. So we're currently scoping up plans and we hope to launch a kind of radical call funded jointly with the EPSRC, looking to take a systems engineering approach to delivery of health and care for people with multiple long-term conditions. We're also trialling a studies within a project model, which would be funding for small-scale add-on work on multiple long-term conditions or methodological development work to sit alongside existing projects, including those funded through the HS&DR programme, among others. So that's a real whistle-stop tour of what ourselves and other funders are kind of interested in. Hopefully I've whet your appetite and convinced you that multiple long-term conditions is an area of strategic interest across funding bodies and that there are exciting and dynamic funding opportunities. And the fact that we're open to applications from established and existing teams and people working in this area, but we also want to bring new teams and collaborations along too. After all, we're all really multiple long-term conditions researchers, or we need to be. Many of the people we see in clinics, the people who take part in research, or those who will benefit from ultimate implementation will have multiple long-term conditions. And we really need to focus on seeing the whole person, understanding what matters to them, and then looking at how we can best configure health and care services to meet those needs. That was a very whistle-stop tour, but look forward to taking questions, comments, or suggestions when we come to the Q&A later.
Thank you very much, Leanne, for a great start. Next slide, please. Now I'm delighted to hand over to Jane Taylor, patient representative in research. Jane has lived with multiple long-term conditions for over 30 years and is a carer for family members with complex needs. She is an expert by experience, member of the expert advisory group to the task force on multiple long-term conditions. I first came across Jane at Foster's Arthritis many years ago, and it's lovely to welcome you to this session. So over to you, Jane.
Okay, thanks, Simon. It's great to be here and give a patient perspective. Can I have the first slide, please? So when I thought about what will I talk about in 5 minutes and what it's like to live with multiple long-term conditions, I actually realized that I frequently do have to talk in 5 minutes about all my long-term conditions, because of course 5 minutes is the average time that I'm allocated to talk to a GP. That is provided, of course, that I can get through, and I am lucky enough to get the golden ticket of managing to speak to a GP. What that means is that those 5 minutes will always consist of what is urgent, what is clinically urgent at that moment. It never consists of what is important to me and what may actually improve the quality of my life. So urgent, not important, is something that sticks with me a lot in terms of time. And sticking with this idea of time and the limitations of time, there's a line that I always think of from a well-known song, which I adapt in my head, which is, "My time is better than yours." And that's something that I think many patients feel, because while my time with professionals is rationed, it often feels like to survive in the maze of the system of long-term conditions, I have to spend not just 5 minutes, but on some days 5 hours. Unsurprisingly, perhaps, many people with long-term conditions end up having to give up work. And that's not always because of the physical effect. That's often because the complexity of the system means that they simply don't have time to do anything else. Can I have the next slide, please? And this is the reason why. This is the average experience of the patient living with multiple long-term conditions and of the carer caring for someone with long-term conditions. And often, like me, and increasingly in society, you end up being both. Lost in the labyrinth. And this is the kind of Kafkaesque nightmare of negotiating a system. Each little part, each little turn in that maze will never quite connect with another part of the system. And you often end up, even if you're very experienced at this, feeling very, very lost and often quite hopeless. And that's because, of course, we still have a system that works on a single disease model where different hospitals and specialists don't communicate, and they rely on you to find your way through that. And they rely on you to actually do the work for them and to connect everything up. Coming back to time, of course, you have multiple hospital appointments, often miles apart. You have lots of monitoring that you have to sort out yourself. And there is the endless hours on the phone trying to get to speak to the right person. And I'm going to use one example. I could choose any, but I've chosen one just to try and give you the reality of that. Can I have the next slide, please? An example I've chosen is polypharmacy. I'm on multiple medications like many patients. And I'm not going to talk here about the side effects of one drug causing other conditions. I think many of us have recognized that that's almost inevitable. What I'm talking about again here is time and the fragmentation of the system and how that really impacts on the quality of my life. So starting with time, I have several prescribers. I have a GP who prescribes several drugs. I also have hospital prescriptions, which of course no longer come from hospitals. They're contracted out to different healthcare at-home companies. I deal with 2 of these. At times in my life, I've had to go and pick up heparin that I've had to take daily from another hospital. That's incredibly time consuming. logistically. Some of these drugs have to be refrigerated. One of them is cytotoxic, so it needs a separate sharps bin. I have to keep on top of all of those. I have to coordinate those. Nobody else does it for me. Monitoring results, I have to do that myself. They don't often get communicated. I live in Manchester. I end up under different trusts, only a few miles apart. But for example, my main hospital now is Salford. Salford is not on the same computer system as my GP in South Manchester. They have no idea what's going on. They can't talk to each other. So I often end up having to get 2 trams, walking either side, to go to Salford to have a blood test that actually I could have 10 minutes down the road. But sometimes it's just easier to do the longer, more effortful thing, because you know you will at least get the injection you need. Inequality is a big feature of long-term multiple conditions. Despite having multiple conditions, I've never qualified for free prescriptions. At one point in my life, I did have to choose which thing I went for, which disease was most important. I know people who frequently have to make that choice on a daily basis. That does not help in the management of their care. Perhaps the most dangerous thing and the most frustrating thing is that, of course, I'm often the only person who knows all the drugs that I'm on because of the problem of data sharing, because of the fragmentation in the system. Once you get contracted out companies provided drugs, it becomes even more difficult because contracts change. There are multiple layers in prescribing. I've had numerous experiences where I haven't got the required drugs because of delays in transport, because dealing with some companies is like dealing with a massive banking call center. No one in one department speaks to another. I've been given the wrong medication, the wrong injections when a new company's taken over the contract. I've been reassured by a nurse who's never met me before, who's come to my house to show me how to do it, that this is definitely what I should be taking. The problems only come to light several months down the line when I'm in front of my consultant and we're both wondering why I've become so ill. So this has a real danger. Very recently, I'll give you the most recent example. I had to come off an immune suppressive because I was on antibiotics for another condition. When I went back on it, it turns out that things have changed again and the GP will no longer prescribe this drug. So I have to get it from the hospital. No one talks to each other. Eventually, I get the GP to sort it out. No one tells me when it's coming, where it's coming from. Eventually, I get quite panicky because I can't get hold of anyone about this drug. I send a long email. 2 days later, 7 a.m., I'm walking by a young guy on a bike who hands me a brown paper bag of drugs, wishes me well, and off he goes. Now, what you have to think here is I live in South Manchester where young guys dropping off drugs on bikes is not an infrequent occurrence. So I did have a moment of excitement, shut the door quickly, had a look inside. There was my methotrexate, but no forms for how to reorder, no idea other than the name of the chemist where this had come from. So this is actually quite dangerous. It's not just time-consuming, frustrating, it can also cause health problems. Final slide, please. So if putting everything into one drug won't help me, what would help me? And these are just some of the points, 5 points, 5 words. Care that was accessible, care that was flexible, care that was integrated, care that was strengths-based, that recognises that actually I've got other roles that I can do in my life. And very, very important, recognising the connections between physical and mental health and how actually poor coordination of long-term conditions can actually have a profound effect on your mental health and your ability to cope with your physical health. If I could have all of that, I would be that happy, smiling person that you see there at the centre, rather than the person that I often am, which is someone sitting very depressed with my head in my hands, wondering which bit of the maze to negotiate next. Thank you.
Thank you very much indeed, Jane, for that very candid overview of the challenges, but also a very clear sense of the direction we should be going in. Right, so we're going to go straight on to hear now from Peter Bauer from the University of Manchester, where Peter, amongst other things, is head of the NIHR Policy Research Unit for Older People and Frailty. Peter's going to talk about how we address the cultural and process-based challenges to funding research and also good practice in multiple long-term conditions research.
Brilliant, thank you, Simon. Really good to speak to everyone today. These are some brief and personal reflections on kind of current state of the art of multimorbidity research and where we might want to go. So can I have the first slide, please? So there's lots of challenges in this area. We are developing a language about what we're talking about, but it's taken us a while to get the right terms. We're still working on the right way to think about multimorbidity, and we're also thinking of the best ways to code and make this information accessible. We've got great data systems in the NHS, but they're not very focused on the needs of patients with multimorbidity. There's a low baseline of current knowledge. What's in the Cochrane review around multimorbidity is not the only indicator, but there's very few studies in that review, so we've got a low baseline. As Leanne said earlier, we're all multimorbidity researchers in one sense, but very few people identify themselves as that, so there's less than an obvious community of researchers. And one thing I've noticed, and I think that's relevant, is a lot of multimorbidity research has a focus on service needs, keeping patients out of hospital, easing pressures on the service, all very legitimate needs. But we've got to bridge some of that gap to what some of in the previous talk that Jane's articulated very clearly around patient-centered goals. So some real challenges. Next slide, please. We are making advances, so we are making advances in terms of consensus on what we're talking about, and the Academy of Medical Sciences report was very useful on that. Major funding has gone into identifying clusters of multimorbidity, so there's going to be some real advances in our understanding of what we're talking about and how these diseases cluster in the community. We've actually got quite granular data as well on patient and professional experience. Jane's just articulated that perfectly, but there's quite a research data now available on these issues in quality research, reviews, reports, and priority setting partnerships. Next slide, please. A big challenge is going to be fixing the gap between those two. If you look on the left-hand side, the MRC NIHR multimorbidity core, looking at clusters, causal mechanisms, mechanistic work. On the other side is the results from the priority setting partnership for patients with complex needs, looking at safe care. And what are they talking about? Whole person care, communication, and being listened to. And these two things don't naturally map onto each other. I know Professor Sayer is going to talk a little bit about this in terms of her walk and how we can take this forward, but we need to be very aware of that gap between some of the work we funded and the needs of patients. Next slide, please. So we need to work on those links, and we also need to be aware of other clusters. People with multimorbidity often have clusters of other challenges, adversity and deprivation, obviously poor health associated with multimorbidity, depression, anxiety, memory and communication problems, health literacy issues. These are really important clusters of characteristics that we need to take into account. These are not secondary to the clusters of conditions they've had. These are very, very important factors for them. And I think, as Jane and others have indicated, we are talking about some quite old problems here. We can get very excited about new approaches and radical changes to research, but coordination of care, shared decision-making, patient-centered care, these are old problems for health services research that we have not cracked. So we need to be aware of that. These are long-standing problems, and we need to reflect that in the work that we put forward. And last slide, please. Sorry, there are a few types of multimorbidity research out there. Some people are, having tested an intervention in one group, are now looking to test that in multimorbid groups. I think that's useful, but that's quite limited. We can't do that with the funds we've got. Some people are looking at multimorbidity as a stress test for long-term condition care, things like shared decision making. If we can do it in multimorbidity, then that's really, really important to show that. And there is now interest, and Leanne's already highlighted this, about radical redesign. If you read Chris Salisbury's paper in The Lancet, he does very clearly indicate that multimorbidity is a fundamental challenge to the way we understand medicine. It's so fundamental, the single disease process, that actually moving away from that is a really profound change, which has really profound implications for the research we do and also the workforce that we want to develop. And those of you who were there yesterday at the workforce session will remember how important this is and how much work we have to do. And the final slide, please. So huge priority, increasingly researchable. We are making progress here in terms of language, in terms of models of research, in terms of thinking through how to do this. It is going to require new ways of working that Leanne's already flagged, new teams, new disciplines being brought in, new ways of assessing outcomes and new methodologies. And there's a cultural issue here. We have to change the way we think about research. And some of this may be about new timescales and indicators of success for research. We can't just do the same things and expect the same teams to come up with radical ideas on the same timescales. And I think partly it's about the right mix. We need some discovery science, and the clustering work's really exciting. We need that patient-led service redesign that Jane's articulated so nicely. Some of this is about radical new approaches to research. Some of this is about revisiting traditional bugbears about service delivery, for example, patient-centered care, looking back at what we've not done previously and making sure we tackle some of those problems that have bedeviled services for a very long time. That's me. Thank you very much. Look forward to the rest of the discussion.
Great, thank you very much, Peter. Lovely. I always really like your can-do attitude that comes through your presentations. It's spot on. So we're going to move on next to hear from Professor Avan Sayah, who's, among other things, the William Leach Chair of Geriatric Medicine at the Newcastle University and Director of the NIHR Newcastle Biomedical Research Centre. And Avan's going to talk about what matters to patients and service organisation, understanding the links between clustering and biological mechanisms, and mapping service design, delivering better care for patients. Thank you, Avan.
Thanks very much, Simon, and good afternoon, everyone. It's such a pleasure to be presenting at this HSR UK conference. As you've heard, my name is Avan Sayah. I'm an academic geriatrician as well as PI for Admission, which is a new UK multimorbidity research collaborative focusing on multiple long-term conditions in hospital. And we're covering everything from burden and inequalities to care pathways and underlying mechanisms. So I want to tell you a little bit more about that today. We actually kicked off on the 1st of March earlier this year. So I'm presenting on behalf of the 17 co-applicants you can see listed here, who come from the 5 centres around the UK shown on the map. Next slide, please. So why focus on multiple long-term conditions in patients admitted to hospital? Well, firstly, we know that multiple long-term conditions are common. 1 in 4 people in England has 2 or more long-term conditions, and this rises with age and with socioeconomic deprivation. They are more likely to be admitted to hospital, where the adverse impact is often immediate. It can complicate and prolong hospital stay and lead to costly, inefficient care in a system that we know primarily was designed for single conditions. And reports on hospital care, such as this one from the King's Fund, recognise the need for reconfiguration of our hospital services, but also highlight that there really isn't enough research evidence to guide this. So that's the bit of the jigsaw that we hope to address with admission. Next slide, please. But of course, we haven't come up with this area of research unaided. And in fact, involvement of patients and members of the public has been central to developing our application. And that started last summer, 2020, with a series of 4 workshops that you can see illustrated here. And it rapidly became apparent that there were major areas to address. And this echoes much of what Jane said earlier, particularly around poor communication and coordination of services. But nevertheless, huge enthusiasm for highlighting this area as a priority for research. Importantly, this input changed our plans and led us to develop various new aspects to our application for funding, including introducing qualitative elements to our work packages and putting in a new focus on care pathways. And of course, we've got ongoing involvement, interaction with members of the public, not least through our two public co-applicants, Victoria Bartle and Ray Holding, you can see here, but also members of our patient advisory group. Next slide, please. So from all this preparatory work, we have developed the vision to transform understanding for patients with multiple long-term conditions admitted to hospital in the NHS and across the world. Next slide, please. How will we deliver that vision? That's the key thing. And we have developed 5 objectives linked to work packages. Firstly, to build interoperable data platforms across UK data sources. Secondly, to develop a systematic approach to defining clusters of conditions in hospitalised patients. Thirdly, to explore how inequalities relate to clusters of conditions. Fourthly, to understand acute care journeys from primary care through hospital and beyond. And then lastly, to start to identify mechanisms underpinning clusters of conditions. And you can see how these objectives are interrelated. And of course, patient and public involvement runs throughout. Next slide, please. So in view of the expert health services research audience today, I thought I'd just say a little bit more about Objective 4, linked to Work Package 4, where we aim to map clusters of conditions in the context of patient pathways to understand hospital-based health service use, what comes before it, and then also what follows. And you can see a sort of simplified illustration of that on this slide. And we're very interested in how care differs across clusters, and are going to look at this in a series of different ways. Firstly, looking at care pathway mapping, and then using routine data to chart journeys through hospital and beyond. And then lastly, understanding the lived experience of patients and carers throughout the care journey. And that's one of the areas we've developed in response to the input from patients and members of the public. Thank you. Next slide, please. So I hope that I've given you just a little taste of the breadth and the depth of this exciting new programme of research. Of course, to have maximum impacts from this work, we are going to have to engage widely and also collaborate widely. So perhaps it's particularly fitting that the first presentation from the Admission Collaborative is to this Health Service Research Conference. And we hope that you will want to engage with us and indeed collaborate. So please do get in contact if that is the case. So last slide, please. I'm just going to finish there with some contact details, and thank you for your attention. And I look forward to the further discussion.
Evan, thank you very much. That's a really exciting initiative, and it's good to see it's so patient driven. That really comes through. I'm sure people are really interested in that. Okay, now we're nearing the end of the presentation, so please get your questions ready. You can put them in the chat box, etc., etc. I know that Natalie Owen's done a really good job also of putting up some useful links for people if you need them, to some of the reports that have been mentioned. So next we're going to hear from Eve Riley, who's the Programme Manager for the Task Force on Multiple Conditions at the Richmond Group of Charities. The Richmond Group has been a really very, very important, I think, motivator and voice in this agenda. So really looking forward to hearing what you've got to say, Eve. Over to you.
Thank you very much, and hello everyone. Thanks so much for inviting me to join this conversation today. So I'm Eve, I'm the Programme Manager for the Task Force on Multiple Conditions, and for those who don't know, the Task Force is a collaboration, so it's between the Richmond Group of Charities, and you can see our individual members on the slide here, and Impact on Urban Health, and it's been supported by the Royal College of General Practitioners. And really at the heart of all the work we've done over the past 3 years has been the voice of lived experience. So really thinking about what it's like to actually journey through the system with multiple long-term conditions. If I could have the first slide, please. So we think a research focus on this area really matters. As other people have said, we know that the evidence base is still limited in comparison to single conditions. And this can mask prevalence. So we know, for example, that in our place of Lambeth, whilst 5% of the local population have diabetes, over 60% of people with multiple conditions do. And then on the other hand, that single disease focus really does miss the combined impact on the person. Too often we hear from people who are faced with a health and care system that doesn't recognise the reality of how their conditions impact them in the round and how they interact and unhelpfully interact often. Next slide, please. We're also really focused on the idea of multiple conditions being a health equity issue. So the burden is really unevenly distributed across a different, range of groups of people, and there's a very significant gap in healthy life expectancy. The pandemic has exposed some of that underlying inequality, and we see on the slide here that if you have multimorbidity, your risk of a positive COVID test goes up significantly. From that same paper, actually, the research shows that compared to white people, people of other ethnicities who also had multiple conditions had almost 3 times the risk of a positive COVID test. And we know that those stats play out then into mortality statistics and more. Next slide, please. So here are the pieces of research that we've done as a task force over the past few years, and I think it tells us something about possible evidence gaps. What was interesting to me in all of the work is that many of the challenges and solutions actually surfaced weren't biomedical necessarily. They much more pointed towards the intersection of multimorbidity with social care, with things like transportation, work, family, finance, impact on emotional well-being, quality of life, things like that. And many people, as Jane said, feel that their conditions plus the effort of managing them have just taken over so much of their lives. That was actually where the title of our second report came from, this sense of overwhelm, and we called the report Just One Thing After Another. So really those repeated themes of loss of mobility, chronic pain, fatigue, can all contribute to sort of social isolation issues and a loss of mental well-being. Final slide, please. So in terms of opportunity areas, we're really encouraging this biopsychosocial research model. We know the point at which an individual person goes from one to multiple conditions varies hugely, but it doesn't vary randomly. It tracks very much issues of deprivation, of culture, of lifestyle, and of place, as other speakers have said. And again, we think this equity lens is a really important one for research. So we know, for example, that Black voices are often invisible in the database, or they're collapsed under the BAME umbrella, as are other groups. And we need to think critically about the types of evidence we use and the types of evidence we value, I think, because the validity of extrapolating learning to groups who might not have been a very meaningful part of that research if they were involved at all, or not involved in the sense making of that research, can be a real problem. And I think that then links to the third point around the importance of co-producing research and understanding that lived experience. I think there's still a gap. So in the evidence base, we have a lot of focus on clinicians' opinions and attitudes. There's still not enough on patient perspectives, even less on families and carers. And I think the impacts of multimorbidity at a household level, which can be very profound. So how do we ensure that patients are included at all stages of research and that they're representative of the whole population, including those people who have traditionally been excluded? And then I just wanted to share a final thought around the concept of research weariness and community skepticism, which has been a real challenge to us and something that we're thinking about a lot within the Richmond group. So historically, there's been a lack of ownership and involvement from the communities impacted by a given research question. And increasingly, we're seeing social research models addressing that gap with peer-led approaches and upskilling researchers from local communities in a way that really builds capacity and really builds ownership. So it's something that we are thinking about a lot ourselves as we think about future research projects that we commission. How can we ensure that our research leaves a positive legacy with the communities that are contributing to it? And then final slide, that's just my contact information. You're very welcome to contact me, and it would be great to hear from you, and looking forward to the rest of the conversation today. Thank you.
Great, thank you very, very much indeed, Eve. That last point about communities and some weariness around research is a really important one, and something I've discovered through my own experience. So we really do need to address that. Right, that's the end of the presentations. Before we go to a sort of open session where people can ask questions, I'm actually going to ask, if I may, Brian Bursford, who should be in the audience, from Newcastle University, to talk about and say a few words about the important role of clinical education in this agenda. Brian, are you with us?
I am, yes. Hopefully you can see and hear me now.
I think we may be able to spotlight you. There we are. Great.
Hi. Well, thank you very much. I think they were all fascinating talks, and I think coming at it from the perspective of a non-clinician but clinical education researcher, I think every point made speaks to a need for educational development and educational research to underpin that educational development. In our discussions up in Newcastle, we've been thinking about, what are the knowledge gaps, and we're starting a bit of work to try and work out what the knowledge gaps are, particularly for medical students. And I think things that have been mentioned, I think that the gap between the understanding of what multiple long-term conditions are and how they're defined and the mechanisms behind them, and that human, person-centered, patient-centered impact, I think, maps quite neatly to two distinct needs in clinical education that I don't think we know enough about yet. On the one hand, it's what is needed for medical students, for new doctors, but also other clinicians to know about how multiple long-term conditions work clinically. But there's a sense of sort of a patient-centeredness has been around as a priority for a long time, but it's kind of patient-centeredness plus. I think there's a need for a more detailed understanding of how the multiple long-term conditions and the non-clinical factors that are associated with them really interact for the patient experience. And I think all clinicians can benefit from more targeted learning and teaching and learning around that. And I think there are lots of questions that we need to ask in the clinical education research area as to which of those are priorities. How do we deliver that teaching and learning? Can it be done in the classroom in the early years? Does it require new types of placements? How do we make sure that the interprofessional and the interagency working that's essential for a successful and satisfying patient experience? I think the logistics side, I think, is essential. Where can that fit in a clinical curriculum? But for the patient perspective, it's essential that care is joined up. So yeah, I think lots of food for thought for us to think about. I'll be interested to hear what others think about the educational priorities and where they lie. Is it for medicine? I mean, there was the point raised about radical change of what medicine is as a discipline. I think there is scope for a radical change of what a doctor is. How much of stuff currently within the scope of a doctor's work doesn't need to be, and might there be a better location of some of that care delivery if it's actually removed from the medical profession? But yes, that was my initial thoughts.
Great, thank you very, very much indeed, Brian. Good to have that perspective. So now we're opening up to questions from you in the audience. And as I say, you can put your hand up or you can put something in the chat. Natalie is going to help me spot people. Have we any initial questions, Natalie? I have one to get people going, if I may, as I take the prerogative as the chair. Leanne, you posted quite an interesting comment in the chat box about the different agendas of the service and patients and carers when it comes to research and needing to close the gap. And I just wonder whether you have any further thoughts on how we close that gap, because it continues to be an issue, doesn't it?
Definitely. Is that for me first,
Yes.
and then perhaps some
Okay,
other panel members to come in, because I think this is a really broad question. I think hopefully the fact that we're having events like this, and we've got the NIHR strategic framework and the multiple long-term condition research funders cross framework, which really put patients at the heart, can kind of speak to shifting that agenda slightly. And I think also my question, and welcome on kind of audience or other panel members' views on this, is how far apart are these kind of issues? And then I think the other point that I would welcome some feedback on, I think that's kind of in Pete's response around how do we collect the data that we need to do research that puts patients at the heart, and to think about the outcome measures. We've had some really interesting conversations about you know, what opportunities new technologies might present, and how we could actually do research that helps people report their outcomes, but also gives them control of kind of joined up medical records. And I think these are some of the kind of radical ideas which really need research to bottom out, but have kind of come up in events.
Yeah. Can you come back on that, Pete, about Peter, about data and stuff? Because
yeah, I think the point's well made. I mean, you know, we research what's easy to research in some ways. We've got excellent data on admissions. We've got excellent data on stuff that's in clinical systems, patient-reported outcomes. They are not collected. The other thing is I think they remain under appreciated. So I worked with Chris Salisbury on the 3D study, which is largely seen as a failure, even though it generated patient-reported benefits. So some of the issues that Jane talked about, it improved people's experience of that, but it was seen as a failure because it didn't change admissions and it didn't change quality of life. So I think there's a cultural issue here, and there's an issue about how we actually sort out the logistics of measurement, because I think it is odd that we don't actually have good data on patient experience across the NHS. You know, given the importance of that and the focus we're putting on it, if I want to know patients' hospital admission rates, I can get that relatively easily. What they feel about their care and how they're currently experiencing that is completely different. So I think there's a huge agenda there on how we start to make that part of core NHS work. Definitely,
and hopefully the swaps initiative that I mentioned very briefly might help with some of that methodological development. So really, we'll push that out once we kind of get that in place.
Thank you. I'm going to come back to Jane in a minute on a question, but first there's one in the chat box which is quite interesting for Sophie, which is, Eve, you pointed it to a significant health inequalities gap. How do we ensure that no one is left behind? How do we ensure that health services research is inclusive for what is really quite heterogeneous population? Do you want to try and answer that, Eve?
I'll have a go. Yeah, thank you. And it's a great question. And it's something that we think about a lot. I mean, we've been, I think for me, it comes back to the issue around community engagement and how we're engaging more widely with people about that have that sort of that knowledge about. So for example, we've been talking about inclusion health populations, and we've been working with friends, families and travellers and some events around inclusion health issues. I think it's about how we are more multidisciplinary, probably, in the way that we're coming at some of these issues, so that the right people are involved at all stages of the research project, because people often ask very different questions depending on where they come from and what their experiences are, and it will fundamentally sort of change the nature of that research. And it certainly happened with us, that we've sort of started in one place and ended up in a completely different one, and it's really enriched the research. And then just to Pete's point, that really struck me about the work that you did with Chris on that 3D trial too. You know, why do we not value as an outcome a patient experience being improved? Like, to me, that is a very valuable outcome in its own right, and we need to think about, you know, the types of evidence that we include and consider as valid.
Thanks, Steve. Aaron, it seems to me that the admission thing has got a really good model for inclusion in this area. It could be a role model for others. Do you want to talk a little bit more about how you've approached it, other than what you already said in your presentation? Oh, you're on mute, Aaron.
Sorry, I think it has been really central to everything we've done with the research. I mean, from the perspective of designing the research, and I described that very clearly, but also in terms of what we want to understand, because we need the breadth. And one of the main objectives is to look at inequalities. And because we're using routine data, anonymized routine data, that gives us the breadth of including everybody, but you need the quality of the data. And one of the things that's striking us already, that when you look at routine hospital data, what is collected? How much do you know about ethnicity? How much do you know about socioeconomic deprivation? I think there's a huge gap there, and something that we could do quite quickly to improve things, to just make sure that we know about characteristics of the patients being cared for in hospital, but I guess wider as well, in order to start understanding some of these inequalities, and to make sure that we are getting the breadth in terms of the services as well as the research we do.
Thank you, Evan. Jane, I just wanted to come to you because I liked a lot of what Brian said about, we've used the word radical a lot this afternoon, but he talked a lot about education, and I just wondered what's been your experience of patients being involved in the clinical education agenda, or even just generally education of professionals, because I get asked that question a lot by patients and carers, and I think there is some stuff happening, but nowhere near enough, is there?
No, that's a really good question. And my eldest child is now working in the NHS, and I see him already, you know, although he's grown up with me and from, you know, very early age had to watch me going into hospital and not seeing me for, you know, a few weeks at a time, but he's already developed that, you know, very clinical focus, which is depressing to me personally. And it just seems very difficult to get away from that. However much clinical educators try and want to. My personal experience is that if I've been asked to be involved in educating, it's been in a surgery, you know, a very short time, talking again about maybe one aspect. What I really think would educate would be for people to actually spend a time shadowing someone, you know, instead of asking them, you know, tell us in 10 minutes what's important, go and actually shadow someone who's living in a particular environment with multiple conditions. Now, I know there are all kinds of safeguarding issues there, but that would tell you so much more about the things that you will never get from a 15-minute conversation, the things you will never even get probably from a patient involvement group, because you will see the very small things which researchers won't think about, but will have a huge impact on that person's life. You know, I have a brother who's schizophrenic, reasonably well controlled as long as it's monitored and he takes the serious drugs. He also has a number of physical conditions. He's incredibly poor. He's never been able to work. During COVID, he's never had a checkbook. He's never had a card. He couldn't use money. He depends on going to shops and getting cheap food when it's discounted. The rest of us had to go out, rush out and find ways, even though I was shielding, of getting him the ability to get food. Those very small things, no one might think about in research, but they have a huge impact on people's physical and mental health. So I think if you can find a way, and you know, the 3D study was one, the Richmond group have been excellent at this, at putting the details of patient experience at the heart of what they've done. And that has changed, as Eve said, you know, the position they started from to where they've ended up. But I think you need to do that kind of qualitative, in-depth research to really understand where you can make the difference.
Thank you very much, Jane. Right, we've only got a few minutes left, but I'm going to come to Leanne now, who I think is going to throw a challenge to our audience. Do you want to go ahead and do that, Leanne?
Thanks. Yeah, that would be good. And it's a shame because I think Asher and Nat have got an interesting chat going on in the chat. So perhaps if there's time for one tiny one more, we might be able to pick up on that. But I think my real challenge is what do you need other than research funding? What can we do to support the kinds of research we've been talking about and make it an attractive area to come into? So kind of what can we as funders do? Because I think I've emphasised that there are a number of funders interested in this. So now's your opportunity to add to the wish list.
Great, thank you, Leanne, and please do shout and put it in the chat box. Ashra, I'm going to you've been posting quite a lot of comments in the chat box, as Leanne says. Ashra, do you want to make your points about vulnerable people falling between the gaps and how research can help? What are some of your ideas here that might be of interest to others?
Hi everyone. So I my work currently is around frequent callers to the ambulance service. So I've sort of been speaking to patients and to healthcare providers, and it's interesting to see that a lot of these patients obviously have lots of different conditions, and health and social care all sort of intersect in terms of their health and well-being and the type of care they receive. And it's just interesting, for example, with housing options in Cardiff, they have nurses who attend the centre, they're based there. They can actually speak to the social workers who are upstairs, speak to the homeless patient, if they've cut their hand over evening, or they're not feeling too well, or they've been sick all night or something like that. So they can attend to patients straight there and then. And it's very difficult to sort of, I know the health services hands are tied in terms of the system. Changing the system is very difficult and challenging. But things even like for people who are at home suffering from loneliness because of pain, or they can't go out, but just having somebody to call during COVID time, a befriender, so that falls into the social prescribing category. I think there needs to be much more joined up working across services, the third sector, social care services and health. And I think we are moving towards that direction. I've been seeing we're moving towards that direction for the last 10 years, but it all depends on the person who's actually running that service, or a key person within that unit who say, you know what, I'm going to do something about it, and then they do something about it, but it's not across the board. Just I'm trying to say is everything's all ad hoc, or so that's my point.
Thanks very much, Ashra. Really good to get that across. Right, we've 4 minutes left, so dare I say this is a bit dangerous, but Jonathan Stokes has come up with a great question, I think, which is, I'll try and paraphrase, and I'm going to throw it out to the panel for anyone who wants to answer it. Are we basically going towards N=1 studies, personalised medicine, and does that mean we need to completely rethink what research is possible, acceptable for funding and publication? Anybody want to come on that? Peter?
Yeah, I think we need some of that. We need some of that within this. There's not one type of research that's going to sort this problem out. It's a huge problem. It's a profound problem. But again, I come back to that Chris Salisbury point. It is chipping away, and I think Brian made the point earlier as well, it's chipping away at some fundamentals. So we do need some very, very different ways of trying to do this. And partly it's about getting new people onto panels, new blood onto panels, because I think I'm a researcher. I'm very different when I'm bidding as when I'm judging. And I'm very conservative as a judge on panels, and we need a way of driving some of that radicalism. I know people like you have done that, Simon, in terms of pushing NIHR in certain directions. So I think it's about having those voices that are going to push us in new directions. And it's a long, that's not going to happen quickly. But I like the idea of those sort of N=1 type studies, because it's a very different way of approaching it.
Great, thank you, Peter. Well, look, that's a good note on which to end. So we've got literally 2 minutes to go. I have it on reliable authority from Jim, our tech guy, that this is the best attended breakout session that he's been of, I think, 8 in total. So it just shows you the level of interest. I think my takeaway is that perhaps since the Academy did its report in 2018, there's so much more focus and so much more collaboration and real momentum, even if we have some way to go to really make a true difference to the lives of people with multiple long-term conditions and their carers. But it's been a really quite exciting hour, and I hope you've enjoyed it. Before we finish, finally, I just want to ask you all to just give a traditional Zoom thank you to our really fine presenters and panel. I think have done a really great job this afternoon. So if you can show your hand claps with the icon or otherwise, that would be great. And just whilst you're doing that, to say that actually the Academy is going to do an evaluation of its original report and what progress has been made in the UK and around the world. So watch this space. But other than that, thank you very much indeed to our presenters. Thank you to Jim, our tech guy. Thank you to Sophie for doing the next slides role. And thank you to you as an audience. I hope you have a very good afternoon. Take care of yourselves. Bye-bye.